Welcome everybody to our Q&A. We hope that you've had a nice day and that you enjoyed all the talk that were provided. I'm Dr. Xavier Kuetgen. I'm one of the co-chairs of this NETRF symposium. And with me today, I have Dr. Chauhan from the University of Miami, Dr. Heloisa Soares from the University of Utah, and then Dr. Andy Liao from the University of Chicago. Dr. Greene is also with us today, and she will answer any questions related to neuroendocrine research and specifically NETRF research. So the way this is going to work is we selected about 10 questions that I'm going to ask. We will hopefully get into a nice discussion. So let's get this off here right away. So the first question that was asked by one of our patients, which is perhaps the questions for Dr. Chauhan. Are there any clinical trials that are currently being conducted to prevent recurrence of neuroendocrine tumors? And I'm assuming that's after surgery.
Actually, I have our star investigator here with me on the panel, Dr. Elyse. Soares. I'd like to highlight one of her SWOG studies. It's actually one of the first of its kind studies, which is looking at trying to reduce the risk of relapse in pancreatic neuroendocrine tumor patients. These are the patients who had a resectable pancreatic neuroendocrine tumor, but at a higher risk of recurrence because of certain factors, could be grade, symptoms, tumor size, etc. And what Dr. Soares and colleagues are doing on the trial is to give a trial of 4 months of chemotherapy, which we know is very effective in pancreatic neuroendocrine tumors, but in the adjuvant setting after surgery to see if it can minimize the risk of recurrence. So it's a randomized study. So some patients will just get standard of care observation, another would get the chemotherapy with CAPE-10. So again, hats off to Dr. Soares for leading this fantastic study, which hopefully will tell us whether these strategies or adding chemotherapy after surgery may benefit. Now, if we see positive signals in pancreas, I think this is a trend that maybe we should investigate in lung NETs and other NETs where we kind of treat them with early stage or with surgery and try to then add adjuvant therapy to prevent the relapse. But yes, that would be probably the premier study right now.
Thank you very much. Okay, so the next question will go to Dr. Soares. So the question is, can you please address the treatment option for grade 3 well-differentiated versus grade 3 non-differentiated? So I'm assuming in this case, poorly differentiated carcinoma. How do they differ and how does the treatment differ? Obviously, that's a whole talk, but just in a few minutes.
Thank you. You know what I was probably going to start saying. There's so much nuances to the question, but I think the first step is we treat very clearly in a very different way the poorly differentiated grade 3s versus the well-differentiated grade 3s. The poorly differentiated grade 3s, we typically start with IV cytotoxic chemotherapy. There's actually an ongoing trial also with the cooperative groups sponsored by the NCI to look into see if in addition to a platinum plus etoposide, which is a traditional IV chemotherapies that we use, if adding immunotherapy to that by extrapolation, which was seen in the small cell lung cancer data, if the immunotherapy will contribute to that. That's a study that's ongoing. And then following that, there's other studies and other IV cytotoxic chemotherapies that can be used, but also the role of dual drugs with immunotherapy. And Dr. Chauhan has been very critical in developing a lot of the treatments for the poorly differentiated neuroendocrine carcinomas. And when we talk about the well-differentiated ones that are grade 3, is really trying to understand the biology of the well-differentiated grade 3. If they light up well in the dotatate scans and they tend to have a more indolent approach, you will treat as any of the well-differentiated grades 1s and 2s. But there are some bad players that might behave a little bit more aggressive that you might end up having to use more aggressive chemotherapies in the beginning. Also now, thanks to the NETR2 study, we know that we can consider PRRT for patients that have a well-differentiated grade 3 tumors. They light up on the dotatate scan and have a Ki-67 less than 55%. And Aman, do you want to highlight any of your studies for the Puri diff? You have so much going on in that area.
It's finally heating up. So I agree. Thank you, Dr. Soares. I think that some of the promising early phase studies are targeting DLL3. You might have heard some news about it. We just had an FDA-approved drug targeting DLL3 through an immune mechanism called BiTE, or bispecific T-cell engagers, for small cell lung cancer, which is a sort of a sister cancers to a lot of our extrathoracic high-grade poorly differentiated neuroendocrine carcinoma. So there are a couple of clinical trials by BI called Darien-5 and several others, so Darien series of trials that we have opened here, as well as several other sites in the US and outside that are looking into this. There are trials. We personally at University of Miami are investigating a bioengineered virus, oncolytic virus called Seneca Valley virus, which seems to be attracted towards neuroendocrine cancer, especially the higher grade kind. And we have some of the animal data, looks very promising, and we are combining it with our traditional immunotherapies. Earlier, Dr. Halperin had a great talk about some of the challenges with our traditional immunotherapies in neuroendocrine cancers. We are trying to overcome those challenges and trying to make these supposedly cold tumor hot, make them immunogenic so that they can respond. So these combination therapies, these are underway as well. And then there are certain trials looking at immunotherapies plus some TKIs with the same sort of rationale to really rev these tumors' immune system to respond. So thank you, Dr. Soares, for highlighting. It's a critical unmet need, and hopefully we can get a breakthrough soon.
Thank you. So, Dr. Liao, these next two questions are for you. So the first one is, before my lung surgery, bronchoscopy showed a Ki-67 of 10%, and then the surgery showed Ki-67 of 4%. Is that possible? So I'm assuming that goes to tumor heterogeneity. And then the second one is, after PRRT treatment with Lutathera and long-acting octreotide, do you continue the long-acting octreotide indefinitely? And is octreotide better than lanreotide?
Yeah, so great question. So the first question, having two slightly different pathology reports from the biopsy and then at the time of surgery, that's certainly possible, and we see it all the time. And that goes to what Dr. Kuetgen was saying about tumor heterogeneity. So if you have, this is your tumor, it may be made up of billions of cells, and if you stick a needle in two different places, you may get slightly different clones of cells, and they may read slightly different. And the other thing is, when we have the surgical specimen, there's more cells for staining for the pathologist to look at. So we definitely can sometimes see minor variations like this from two different biopsy specimens. And then the second question is also a good one. Do we continue the somatostatin analog after PRRT treatment? Well, the NETRF study, which was the study that PRRT approval was based on, they did continue the somatostatin analog. And so in our practice, we tend to, especially if the patients have carcinoid syndrome, if we're giving the somatostatin analog to control their hormonal secretion symptoms and things like that. But, what about a patient who had previously, their tumor had progressed on somatostatin analog? Is there value to continue on? I think that's a question that remains to be answered in future studies.
Great. And is lanreotide better than octreotide?
They're two different brands. They both work the same way. They're both somatostatin analogs, and they're delivered differently. One is an intramuscular injection, the other one is a deep sub-Q. We consider them to be clinically equivalent. Of course, there's no head-to-head comparison study. Patients may have anecdotal experience of liking one versus the other. We know they definitely have different pharmacokinetics. So after the shot is delivered, how it hangs out in your body is a little bit different.
Great. Dr. Chauhan, as a follow-up for the heterogeneity question, is there any particular way that you deal with heterogeneity within the same surgical sample? Let's say, somebody goes to debulking and, or even within the same biopsy sample, and you have different types of Ki-67s. Do you treat the highest, the lowest? Do you take the average? How does that work?
Thank you for that question. It's unfortunately one of rather common scenario in our area, discrepancy of Ki-67 and tissue-related issues. And even with the same set of slides, there is even data to suggest that two different pathologists might have different interpretations. One of the pathologists actually told me it's like counting the cows in a herd, right? So it's not a perfect science. However, we recommend that pathology be reviewed at a high volume center where the pathologist is in tune with seeing these rare cancers. Now, when we see these discordance between low Ki-6 and high Ki-6 or low mitotic index or high mitotic in tumor, by definition, we have to grade the tumor based on the highest grade. That will define the biology of the cancer in majority of cases. So if it's a Ki-6 and 12% at certain area and 1% at certain area, this will be a grade 2 neuroendocrine tumor. And I would be compelled to watch this patient more closely because I expect this might be a more faster growing tumor. So those are some of the clues from pathology. However, in real time, we can also do molecular imaging to kind of help us understand the true biology. So if we are dealing with a metastatic disease, so we can do DOTA-8 PET scan and look at the somatostatin receptor expression, which majority of our GAPNet patients will have very SSTR-avid disease. However, if we are dealing with a grade 3 or higher grade 3 well-differentiated NET, as the grade increases, sometimes the receptor density comes down and they become more de-differentiated. So we might see certain areas which are not lighting up as avidly on a DOTA-8 PET, which will trigger me to do an FDG PET, which is a common PET scan that we do in common cancers. And if it lights up, that suggests it's a more aggressive biology. These tumors are taking up more of the radio-labeled glucose. At the end, the ultimate decision is on the biopsy. So if my suspicion is high that there is discordance and there's a heterogeneous disease, it's not all same disease, and there are areas of high-risk disease with higher grade, we end up doing a biopsy to eventually confirm, because at the end of the day, the biopsy trumps everything. It's the final word.
Thank you for this clarification. So the next question is for me, so everybody can just lay back and relax. Is the preferred treatment for a gastrointestinal neuroendocrine tumor still a hemicolectomy? I had heard that this may no longer be true if a tumor is able to be fully removed. So that's a great question. And as a matter of fact, I've seen a similar case not too long ago. So a hemicolectomy really only needs to be done if the small bowel neuroendocrine tumor is in a very distal part of the small bowel, where the blood supply to that distal part of the small bowel is actually also the same blood supply to the right colon. And when we remove a neuroendocrine tumor, we would want to remove those lymph nodes, and those lymph nodes run around the blood supply. So it's really important to understand how these tumors drain their lymphatic channels and where the lymph nodes can be found. So again, if it's in the distal part of the small bowel, you're not going to get along trying to just remove the distal part, because you'll devascularize some part of the bowel, which is in this case the right colon, that then will have to be removed as well. So distal part of the small bowel, always get a right hemicolectomy. If it's anywhere else in the small bowel, and there certainly can be anywhere in the small bowel, although the most common location is the distal part of the small bowel, then no, you don't have to do a right hemicolectomy. You can actually just do what's called a small bowel resection. So you just remove the segment of bowel with the lymph nodes and the mesentery to be able to harvest as many lymph nodes as possible. One of the things that Andy and I have seen, I think last year, was a patient that presented to us where it was proposed to her that the endoscopist, through a colonoscopy, would try to carve out a tumor in the distal small bowel. So that's a bad idea. Why? Because these tumors tend to be in the submucosa, and so the risk of perforation is quite high, and also you're not going to clear out those lymph nodes. So endoscopic resection of neuroendocrine tumors can be done. They can be done for rectal neuroendocrine tumors that are small. They can be done for gastric neuroendocrine tumors that are small. They can be done for duodenal neuroendocrine tumors that are small. That's not a good option for small bowel neuroendocrine tumors, just because of generally the locations. These tumors tend to be a lot deeper within the layering of the bowel, and the risk of perforation is very high. So that's my answer to the question. Unless there are any other comments, I'll move forward to the next one.
I wonder if the person that is asking the question is also thinking about the appendix.
So
can you comment on that? Yeah.
Yeah, that's another great question. So appendiceal neuroendocrine tumors are very often found incidentally, right? We often don't know that patients have these tumors, and when they develop acute appendicitis, the appendix comes out, and then they have essentially an appendiceal neuroendocrine tumor on the final pathology. Now, is the right hemicolectomy necessary for an appendiceal neuroendocrine tumor? It depends. It depends on a lot of things. And even there's still controversy. We had a great NANETS talk, if you remember, all three of you, last fall in Montreal. But essentially, if appendiceal neuroendocrine tumors are low grade, which they almost always are, if they are in the distal tip or away from the base of the appendix, and if they are less than 2 centimeters, generally speaking, they're considered not invasive enough to require any additional surgery. So generally, an appendectomy is more than enough. There are some studies that suggest that for T3 tumors or tumors that invade into the mesoappendix or through the serosa up to 3 millimeters, that those are at higher risk to develop lymph node metastases, and therefore right hemicolectomy should be done. We're pretty conservative at the University of Chicago generally, and this is only one study that had really shown that the risk of a lymph node metastasis is higher. So generally, if there are not any other features, if on the CT scan or on a dotatate PET, which we can also do sometimes after these cases, there is no suspicious lymphadenopathy. We generally, even in those cases, will tend to surveil. How long you surveil is a whole nother question for debate. And again, there was an actual debate at NANETS about that. Do we just do 1 year and then that's it? Or should we follow up for 10 years? That's up for grabs. And I think we need more studies to define that. Our practice at the University of Chicago, and certainly I'm curious to see how they do it at the University of Utah and University of Miami, is that if it's a low-grade tumor with a low risk of recurrence, we generally tend to actually repeat a scan a year later. And if nothing shows up, and it's really in the low risk category, we tend to then stop following them long term. The other question is the role of dotatate PET, right? Should we really do a dotatate PET on everybody? Should we do it a year later or just a regular CT scan? Again, a lot of different things that are still up for grabs and need to be questioned. Okay, let's move on to the next one. So, do we understand if and how neuroendocrine tumors or neuroendocrine carcinomas can be passed on to our children? And is there any testing that we need to do or that can assess the risk of developing neuroendocrine tumors or even symptoms?
So for the majority of the neuroendocrine tumors, there is really no genetic association to the point that you were born with a germline mutation that makes you predisposed. So for most of the patients, no, we don't know, and there's no risk that your family or your children will have that. There is about 10% of patients that will have a germline mutation associated. Typically in the family, there will be more family members with the particular gene. M1 is one, VHL is another one, and there are many. And then if there is a suspicious that by history or any other features that it could be actually a tumor that was generated because of germline mutation, there is blood work that can be done. And if it's positive, then there is a significant counseling with genetic counselors. They will be advised to have the family members that are first-degree family members to be tested as well. For most of the patients with GI neuroendocrine tumors, there's very little association. For paragangliomas and pheochromocytomas, by default, they all should be tested because the chances of having a mutation is a little bit higher. But for the lung and for GI, well differentiated is the minority of the patients.
Thank you. Next question is for Dr. Liao. After my second PRT treatment in concordance with long-acting octreotide, my scans showed more tumors and growth. The question is that a common scenario? And I would add a couple more questions to that is, how do we routinely scan after 2 cycles after PRT? And if there is progression that's believed to be true progression, should we continue or should we stop at that point and switch gears?
That is a great question. In our practice, we do scan in the halfway point, so after 2 of the 4 cycles. And really, it's only because every now and then we see patients whose tumors are growing so rapidly that they don't respond at all to PRT. We want to identify those patients to take them off treatment that's not working. But to answer the original question, it just depends on how much more growth there is. Is it kind of mild growth or is significant growth? We know that PRT sometimes can cause kind of a flare phenomenon, can make the tumors swell up a little bit before they start shrinking. And so we want to be mindful of that phenomena. So, if the patient is doing clinically well, for instance, if their carcinoid symptoms, their diarrhea is getting better and all that, then we wouldn't necessarily consider that true progression. We would kind of keep pushing forward and continue the third and the fourth round. The other thing to consider is the comparison of the scan, what you're using as a baseline, right? So if you're comparing to a scan that was done a year ago, which sometimes we do the PET scans once a year, that may not necessarily mean that PRT is not working because PRT wasn't started until 4 months ago. So those are all things we have to keep in mind.
And then if somebody would be considered to have true progression, so not pseudoprogression or swelling of the tumors, is there, and I know it's probably on a case-by-case basis, but would you generally recommend to stop after 2 cycles, or would you?
Yeah. So we have seen this in a minority of cases. We have seen patients whose tumors are growing so rapidly, and usually patients can have the associated symptoms too. They're not doing well, they're losing weight and things like that. Sometimes if it's out of proportion to what we expect, we may send them to get a repeat biopsy. And sometimes I've seen on cases like this, when they have dramatic progression through PRT, when we do the rebiopsy, they actually have a poorly differentiated neuroendocrine carcinoma clone that was emerging, for which the PRT was not the right treatment. So they need to be on chemotherapy.
Great, thank you very much. So one of the questions here, it's kind of a surgical question, but I'm going to ask it to you because I know you love surgeons so much. So the patient says here, if you have 4 or 5 small, less than 1 centimeter lesions in the liver that are metastasized from a small intestinal neuroendocrine tumor, would you, as an oncologist, ever send these patients to surgery, or would you consider continuing another therapy or starting another therapy, or is there generally a sort of a threshold of when you send patients to surgery?
Well, and I do have soft corner for surgery. In fact, my first neuroendocrine tumor project paper and presentation was SSO. I have a soft corner because I have seen, I think surgical site reduction debulking can make a lot of difference in patients, definitely in a functional NET patients. In non-functional NET patients, absolutely. If you have a good surgeon, you have a good debulking, 90+%, and for sure, the usual critique is lack of prospective randomized data with proven outcomes. In cancer world, we are pretty tough on ourselves. We really want to show overall survival benefit. In disease like NETs, this is difficult to show. And the next best step is surrogates like progression-free survival, etc. And unfortunately, we don't have that. So that's where this whole debate between surgeon and medical oncologists and others come up. Hey, are we selecting a good patient we will have done regardless very good, right? I was at a meeting with Dr. Fisher recently. He showed me a patient with metastatic disease. And this patient with metastatic disease had completely stable disease for 13 years with no treatment at all. Didn't need a medical oncologist, didn't need a surgeon, right? So we really have to individualize the treatment. That's the uniqueness of neuroendocrine tumor, right? So the key here is biology. I would trend the biology first. If it's going to declare itself, it's going to be more lesion in the near future, waiting for a surgery is probably a good idea. You don't want to subject a patient to surgery and then 3 months later, there are new lesions. At the same time, if it's a more indolent cancer, for sure, I'm going to always ask my surgeons or my colleagues, hey, this patient is otherwise relatively low bulk cancer, and we are looking at very good long-term prognosis. Can we cytoreduce? There is data to support, like yours and several other prominent surgeons, that certain patients can certainly benefit. So I don't think there's a cookie cutter answer. And that's where I feel people like us have a job security, because it's not easy. We have to really individualize cancer based on individual patients, prognostic factors, tumor growth rate, the grade of the disease, burden of disease. And this is especially for non-functional patients. For functional NET patients, yes, I'm more liberal in sending them for cytoreductive surgery early on, because taking as much tumor out certainly can help them in the short interval for symptom management at least.
Yeah, thank you very much. I think this is, it's a good answer from a non-surgeon even. I really appreciate it. I think in this particular case, with 4 or 5 small, less than 1 centimeter neuroendocrine tumors in the liver, I would agree with you. I don't think surgery is necessarily the best way moving forward for 2 reasons. Number one, like you said, biology, right? It's important to understand. So you could either not treat them or maybe start them on octreotide, especially if they are symptomatic, sort of see what happens. But also the bang for your buck, right? Because like you said, generally surgery, it's still surgery. It's, debulking surgery is a lot of surgery. You have to recover from it. And certainly going in there to remove 7 millimeter lesions is probably not worth a surgical operation, because it can be done at a later time point when the liver tumor burden is higher. So there really is, I think, in my experience, a sweet spot of not waiting too long until the liver tumor burden is so high that debulking is off the table, and also not going in too early where, ultimately, what are you really going to achieve? You have a big surgery to remove 4 really tiny tumors. Micrometastatic disease is going to be growing over time and show up again on the scan. So I think these are really different consideration, and like you said, very well on a case-by-case basis need to be considered. So that's it for us. But I have a last question for Anna, and that question is, how do you feel NETRF research has impacted the change of treatments in the neuroendocrine tumor world over the last 5 years?
Yeah, so we play a large role in funding research in this space. And, I've heard from a lot of the talks today, people would follow up and say, well, more research is needed. And we agree. We think there's a long way to go to, greatly improve how we early detect these tumors, how we treat them in a more precise manner, and how we can cure them, right, through treatments instead of stabilize them. And so NETRF plays a role in funding research in all of these spaces. But in terms of the last 5 years, I think we're really excited about these targeted treatments that have come onto the market. We're really excited about CAR T therapy, which we've funded for the past decade and is now in clinical trial. So we're excited to see what comes from that. And so we feel very hopeful that we're going to get to a place where patients have even better outcomes than they do today.
Thank you so much. And this ties in together nicely with the topic of the conference, which was hope. I think we can all agree on this call that hope is probably the most important thing for our patients, but also for us. I think we do this because we are hopeful that our patients are going to do well, and we are hopeful that one day I can stop doing surgery. Dr. Chauhan can, retire to a nice island in Florida. Dr. Soares can go skiing every day. And then Dr. Liao, I know Andy very well, so he loves eating at good restaurants and traveling. So Andy could travel the world and eat at good restaurant. So we are very grateful that you were here with us today. Thank you so much for taking the time to prepare this conference. There's a lot of work that goes into this conference. We are very grateful that you took the time on a weekend also to be with us. So again, thank you very much. And we hope to see you next year for another conference.
Thank you so much, Dr. Kuetgen.
Thank you.
The team of NETRF.
Thank you.
Thank you.
Thank you for attending Know Your Nets and spending this time with us. We hope you've learned a lot and enjoyed the program. Thank you to all our presenters who gave their time and expertise. And a special thank you to our thrivers who shared their stories and valuable advice. Know Your Nets is possible because of support from our co-sponsor, University of Chicago Medicine, and all our sponsors, Novartis, RayzeBio, and Crinetics. Thank you. I want to recognize our NETRF team. This is a team effort with special thanks to Jessica Thomas, Jennifer Long, and Christine Coffey for the tremendous work to bring all of you Know Your Nets. If you missed any parts of the program or want to watch it again, we will be posting the program on our YouTube channel. You'll also be receiving a survey in the next few days. We'd love feedback, positive and negative, so let us know what you learned and what else we should include in future programs. If this program has been helpful to you, please consider supporting NETRF. We depend on community support to provide our educational resources. You can visit our Net Knowledge Center at netrf.org for more information on our guide, our podcasts, videos, and other online content. Thank you so much for joining us. Remember, NETRF is here for you. You're not alone in this journey, so take care, Have hope and thrive.